at junior doctors who work on a ward in theatre and in acute care. I will cover the legal basics, everyday steps you can take to reduce dose, how to manage pregnancy issues for patients and staff, and what to do if something goes wrong. I will pause for 2 short polls and 1 interactive case during the talk, and I will leave time for question at the end. So let's get started. First, what are the learning objectives? By the end of this session, you will be able to first understand the legal rules and regulations for medical radiation in the UK. Second, apply ALARA and the 3 protective measures in everyday practice. Third is to recognize typical patient doses and how to discuss them with patients. And fourth, know the key escalation routes for pregnancy, high dose procedures, incident reporting, and suspecting of exposures. By the end of this session, you'll be able to do these 4 things. I'll remind you of them at the end. So let's begin with why radiation safety matters. Radiation safety is an extremely useful diagnostic and therapeutic tool, but it carries both risk to the patient and staff. Good practice means we accept exposure when the clinical benefit outweighs the risks, and we reduce avoidable exposure. Right now, I have a quick poll to warm up. So if you can answer in the chat, which modality do you request the most? If you can just type in a Zoom chat.
There are lots of people saying X-rays.
Yeah, I think everyone has a tight request X-ray in everyday practice. Okay, yeah, so majority chose an X-ray. So now it's important to have a distinction between ionizing and non-ionizing radiation and why it's important. Quick but crucial distinction: ionizing radiation, X-rays, CT, and many nuclear medicine tests can remove electrons and damage DNA, which is why we worry about radiation risks. And non-ionizing modalities such as MRI, ultrasound do not involve ionizing radiation and so do not carry that risk. Practically, whenever the critical question can be answered with MRI or ultrasounds, those are preferred alternatives because they avoid ionizing exposure. So now we'll talk about core principles, the rules we should follow. The 3 pillars of radiation protection are justification, optimization, and dose limitations. Justification means each exposure must have a clear clinical benefit. Optimization follows a ALARA rule, means we must keep dose as low as reasonably achievable by reducing time, increasing distance, and using shielding. And dose limitations refers to the legal limits for occupational exposure and special groups. A short phrase to remember and use: justify, optimize, and limit. And when you think about ALARA in practice, think about time, distance, and shielding. Okay, now how are those principles set out in UK laws? In the UK, medical exposure are governed by ionizing radiation and medical exposure regulations from 2017 that sets out who can refer, who is a practitioner, and who is an operator, and imposes duties around justification and documentation. Occupational protection and working dose limits are set under ionizing radiation regulations 2017 and implemented by Health and Safety Executive and local radiation protection advisors. Employers are responsible for compliance and must provide arrangements such as radiation protection supervisor and ionizing radiation practitioner. The practical implication for you as a clinician is to know your local contact and to follow local protocols. So what does those roles mean day to day? As a junior doctor, you are most often the referrer. Your duty when referring is to provide a clear clinical question, relevant clinical information, and to ensure the test is likely to affect management. That is a sense of justification. The practitioner, often the radiologist, carries formal responsibility for the clinical justification and selecting or agreeing the protocol when necessary, and the operator performs the exposure per the protocol. If you are unsure where imaging is needed or which imaging would be the best, it's recommended to call radiology. That conversation is clearly supported by ionizing radiation and medical exposure regulations and is good practice. Now the key numbers to remember for staff safety. Important number, the adult worker effective dose limit is 20 millisievert per year. If a member of staff declares pregnancy, the employer must do a risk assessment and aim to keep the fetal dose to about 1 millisievert a year. That is a commonly used fetal constriction for the remainder of pregnancy. There are separate equivalent doses limit for specific tissues. For example, the lens of the eye is about 20 millisievert a year. Note this may be averaged across a period in some guidance, and the skin and extremities have a much higher limit, commonly around 500 millisieverts per year. Always present this as approximate and point colleagues to local occupational health and the radiation protection supervisor for exact local rules. If your dosimetry badge record an unexpectedly high reading, report it immediately to your radiation protection supervisor or occupational health for investigation. Next one, patient dose and how to put them in perspective. Here are some approximate typical values to keep in mind. Emphasizes these are center and protocol dependent. Average UK background radiation is about 2.7 millisievert per year. A chest X-ray is tiny, around 0.01 to 0.02 millisievert. A chest CT is typically around 5 to 8 millisieverts, and a CT abdomen pelvis is typically 8 to 12 millisievert. When speaking with a patient or colleagues, always allow for local variations and reference to your trust diagnostic reference levels if available. Use these comparisons to help to explain the scale rather than exact figures. And how to say that simply to the patient. When talking to the patient, keep language straightforward and comparative. For example, this CT chest will expose you to about 6 millisievert, which is roughly equivalent to 2 to 3 years of natural background radiation. Then immediately follow with a clinical benefit. The scan will give us information likely to change your treatment. For low dose tests, reassure and move on. For higher dose or elective tests, document that you discuss the risk and benefit and record the clinical justification in the notes. Practical things you can do now to reduce dose. Every request should begin with a question. Will the result change management? If the answer is no, don't scan. If the answer is yes, consider whether ultrasound or MRI could answer the question. Since they avoid ionizing radiation, use local low dose or pediatric protocols and optimize acquisition parameters. For CTs that might be lower kilovolts, iterative reconstruction, and appropriate collimation. If you're unsure, brief telephone advice from an on-call radiologist is often quick and will often identify a lower dose alternative. Fluoroscopy and CIRTA have specific practical measures. In CIRTA and fluoroscopy settings, always apply time, distance, and shielding. Minimize fluoroscopy time, use pulse fluoroscopy, and last image hold. Staff should increase distance from the source when possible and use ceiling-mounted shield in preference to apron-only protection. Thyroid shield should be used where appropriate. Include expected fluoroscopy time and radiation safety roles in the team brief before the procedure so everyone knows who is monitoring those and where shields will be placed. For interventional cases, plan ahead. Interventions such as complex endovascular work or CT-guided ablations can deliver significant dose. These cases need a pre-procedure briefing with an expected dose plan. For example, anticipated DAP, which stands for dose area product, or cumulative air karma, which stands for the summary of radiation energy delivered to a point in air, and clearly assigned responsibility for radiation protection. Ensure active dosimetry is in place and your local radiation protection supervisor is involved if case could be high dose. If you are assisting, know where the shielding monitor and dosimeter badges are and follow the agreed protocol to reduce unnecessary exposure. Pregnant patients require a clear, cautious approach. When a patient might be pregnant, ask politely and early. For suspected appendicitis in pregnancy, the usual pathway is ultrasound first, MRI if ultrasound is inconclusive and MRI is available, and CT only as a last resort because it involves ionizing radiation. If a CT is unavoidable, use the lowest feasible dose and document the justification and consent discussion. Always record the clinical reasons why MRI or ultrasound were unsuitable if you end up choosing ionizing images, and ensure that discussions about risk is documented in the notes. And for the staff who are pregnant, if a member of the staff suspects that they are pregnant, they should inform occupational health or their employer as soon as possible. That triggers a formal workplace risk assessment. The employer must then aim to ensure the fetal dose is about 1 millisievert or less for the remainder of the pregnancy. And practical adjustment might include rota changes, avoiding fluoroscopy list, or shifting duties. Reassure staff this is a routine protective measure and not a disciplinary action. Simple adjustments normally provide effective protection. Handling dosimetry in a day-to-day practice. If you classify to wear a dosimeter badge, wear it correctly and check the issue and return schedule so you know when readings will be reported. Readings will be monitored monthly or quarterly depending on the trust, and local action levels trigger interventions. If a badge exceeded an action level, report immediately to the radiation protection supervisor and occupational health. There is a local pathway for intervention and follow-up. Do not hide or ignore a high badge reading. Early reporting protects both you and patient and helps identify system issues. If anything seems wrong, report it. Any accidental or unintended overexposure must be reported under your local ionizing radiation and medical exposure regulations policy. The ionizing radiation practitioner and radiation protection advisor will lead the investigation and advise on patient communication and any corrective steps. Remember, reporting is about patient safety and learning, not blame. If you suspect an overexposure, contact radiology, governance, and ionizing radiation lead immediately and record the facts clearly. So, how to talk to a patient and document consent? When obtaining consent or discussion images, keep it brief, factual, and comparative. And template phrases you can use. This will help you answer X. The radiation dose is about Y millisievert, which is roughly equivalent to Z years of background radiation. On balance, we recommend it because then you provide clinical justification. And for higher dose or optional studies, make sure that you document the discussion and the clinical justification in the medical record. Clear, simple statements reduce anxiety and provide a record that discussion happened. So let's apply everything in a short interactive case. For example, we have a 28-year-old woman with a lower abdominal pain. Pregnancy status is uncertain. So what is the best next imaging steps? You have 4 options. Please type them in the chat. What do you think is the best image for this scenario?
Most people have said A.
Okay, so yeah, A is correct, but the recommended approach is A and then B, ultrasound first and MRI next if ultrasound is non-diagnostic, and CT is a last resort in pregnancy because of fetal exposure. And if CT is used, document why ultrasound and MRI were unsuitable and record the consent discussion. This highlights justification, alternative selection, and documentation in practice. And now let's move on to quick knowledge check. Just try to answer in a chat. If we got 3, so here we got 3 true and false statements. If you can just type your answer in the chat. So first one is under ionizing radiation and medical exposure regulation 2017 policy, every exposure might be justified as having more benefits than risk. Is it true or false? Yes, so that's 100% correct. Under ionizing radiation and medical exposure regulation from 2017, the practitioner has a legal duty to justify every medical exposure. And second one, a single chest X-ray has negligible dose compared with a CT scan. Is it true or false? Yes, so this is true. A chest X-ray ionizing exposure is hundreds of times lower than a CT scan. And third one, you should never request a CT scan for a pregnant patient. Yeah, this is false. CT may be justified if the benefit outweighs risk and alternatives are unsuitable. These answers correct commonly misconceptions and show how just judgmental matters. And now we'll speak about final practical takeovers. So here are 10 quick things to remember. The first one, always justify, we will change management. Prefer ultrasound and MRI before CT. When clinically appropriate, use local dose and pediatric protocols. Minimize fluoroscopy time, use post mode and collimation. Step back and use sewing shield in theater. Wear and respect personal dosimetry. Declare pregnancy early. employer will take steps to protect fetus, document patient dose, discussion for high dose tests, report unexpected batch reading and incidents promptly, and keep local ionizing radiation and medical exposure contacts handy. If you only do these 10 things, you will substantially reduce avoidable risk. And here are some useful links from the Royal College of Radiologists and the UK government and the UK Health Security Agency. So please feel free to take a screenshot. You can review them later for the detailed guidance. Okay. Thank you everyone for attending. If you have any questions, please type them in the chat. And also don't forget to scan the QR code so you can get a certificate of attendance later.
Okay, thank you. Thanks, Ross. That was quite interesting, and especially attending from now listening to the talk from the other end of the spectrum, because I'm not the one who has requested imaging in a while. So we are at the end where we are accepting or rejecting. Most of the times just accepting the requests now. And like when you asked like which is the most common modality, I was thinking maybe CT, because that's what we think
That's
that
what you report.
requesting, like every patient who comes into emergency department just gets a CT done. So, but just from clinical practice, like how many of you who have IRMA in while requesting the studies, because our trust has recently implemented, and do you think it has made a difference? Would you guys let me know in the chat? Are you guys using IRMA in while you're requesting?
No. So what is EMA?
No, the IRMA that you were requesting. So every scan that you request like a CT, you have to give a justification that it fits the criteria. So I'm not sure whether you guys are using it. So previously, if you're not using it, so like for example, like for a CT head, there's a certain NICE guidelines that you have to follow. So like, for example, if the patient is this much age, more than 65 on a PICSA band, or even if there is a silver trauma or a fall, the patient would get a CT head. But if they're not, then there's specifically if there's loss of consciousness, fitting. So it's easier for also for the clinicians just to tick mark that like it fits this criteria, and then it would automatically be, the request would automatically be accepted by the radiographers even. So not all the requests, they have to go through the radiology registrar or a consultant. So is anyone else using that in the audience? Are you guys using it in your trusts?
It's not in my trust, but it will be quite useful to avoid exposure and also remove like unnecessary calls to radiologists just to ask if it's the best image.
Yeah,
Yes.
I think it has helpful. I don't think it has made a difference in the number of requests. That's what people were asking, but probably it just justifies that they need the scan for also. Also, I think the pregnancy one was quite good because you had put the statement like you never use it. Yes, it's not the first line. You would probably first of all rule out if the patient is pregnant. You can do a urine pregnancy dip and then just confirm if the patient is pregnant. For example, appendicitis, even for ovarian torsions, ultrasound would be the first modality. If the patient is clinically stable, patient can wait till the next day to get an MRI done. Very unlikely would do a CT unless I remember during COVID times, lots of patients were presenting with shortness of breath, and then obviously the D dimer is not that reliable if you have COVID. We used to get lots of CTPAs done even with the pregnant patients, but then they had to document all the discussion they had with the patient because not all patients can have the VQ scan the next day because of limited service. And even the VQ scan is not 100% conclusive. So obviously CTPA is gold standard. So I remember one of my colleagues' wife, she turned up and then she had COVID, but then shortness of breath. And then we ended up scanning her. Um, So yeah, but a bit unlikely for pelvic pathologies. I think ultrasound now it's operator dependent, but if you can get the good scan done, it probably can reduce minimize the risk of exposing the patient to radiation. Yeah. Any questions, guys?
I can't see any questions in the chat.
And how have you worked in trauma? I think, Ross, you have before.
So I had an interesting case where I had a patient. She was 6 months pregnant, and she went to the swimming pool. She had a fall, and she had a fracture dislocation of her ankle. So yeah, we took all the precautions for this case, but that was a lot of discussion and communication with, like, we involved everyone. We involved anesthesiologists, we involved gynecologists, as well as radiologists. So we also make a lot of consents. That is, we need to do an X-ray to manipulate it under CR machine to avoid unnecessary radiation in future. But definitely, this kind of cases takes a lot of more time, more communication, more discussion, and you think twice before do any radiation exposure to such kind of patients.
Now, I was just thinking, do you still have detailed conversation with patients even for X-rays for like, or if in this case she was probably pregnant, or only for CTs?
No, that was for X-ray guided. So we use a CR machine to
Yeah,
manipulate ankle.
fluoro, okay,
Yeah, so
yeah.
there was a lot of discussion, and it involved like probably half of hospital in this conversation, and patient agreed that this is the best way.
Yeah, because I remember even the radiographers for scanning every patient for the CT, they have to sign all the female patients, they have to sign a form, or the ED, sometimes they have to do the urine pregnancy test. And sometimes if the patients refuse, then they have to sign specifically a form because there's quite a risk. Because I remember there was a patient, I don't know what happened, but then obviously like accidents or like mistakes happen. And then, so in before starting the scan, there's always a scout image. I don't know if you have seen like on your images. So it's just like a picture, small picture that they have taken. So they only took a scout image, but then they realized there was fetus. So I think they just stopped there, obviously. But then it has to be day-text, and it has to go through the radiation protection supervisor. Then you have to tell the patients. Sometimes patients are not even aware that obviously they don't know that CT has got radiation, and then it would be harmful for the fetus. So then you have to, it's like a duty of candor. So you have to apologize to the patient, and sometimes the patients have to be monitored throughout their pregnancy for increased risk. Okay, there is a question which has come up. Does a CT of head, chest, or joints affect pregnancy too, or is it mainly CT of the abdomen that are concerning? I think it's whenever you radiate, obviously that part is gonna get, but it's you can't. There is a scatter radiation also. Obviously any patient who is going into the scanner, even if it's get a head scan, but the patient is pregnant, there's still a risk. Like for example, for CTPA, the main risk is not that much to the fetus, but there's also a risk to the breast tissue because that is very sensitive during pregnancy, and there's a risk of developing breast cancer. I mean, every radiation exposure has a risk. So you can see it also depends because your body is sensitized. So it can affect other, there is a risk, so it increases the risks of other things.
So for example, if patient is breastfeeding, you also consider ionizing radiation.
Yeah, you will have to probably. Like for any procedure, I think. Like for example, we get lots of requests for MRI heads in pregnant patients coming with headaches, and also there is a risk of venous sinus thrombosis. If there is any risk factor, and also like pregnancy is also, your coagulation profile is disrupted. So we end up doing lots of MRVs in the pregnant patients rather than a CT venogram. Although CT venogram is more superior than MRV for looking for small clots. But yeah, just for safety, they don't discharge the patient, sometimes keep them in. Yeah, so it's more like which modality is best, but then also more the risks versus benefits.
Okay, that's interesting to know.
Okay.
Is there any more questions?
Yeah. Okay.
Okay, thank you everyone for joining.
Yeah, thank you everyone. And if you have any further questions, just do let us know. And just feel free to scan the QR code. And we have shared the feedback form, is it, Louisa?
It's on the chat.
Yeah, okay, cool. So yeah, fill in the feedback form, and if you want the certificates, then we'll be able to send you the certificates with your details on it.
Thank you everyone for your time. Thank you for joining.
Okay, thank you everyone.
Make sure you join next sessions. We'll keep you updated on our social media.